Welcome to the American Lung Association's webinar, Tobacco Cessation and Private Insurance under the ACA, New Opportunities for Public Health. This webinar will be recorded and posted online. Please hold questions to the end, as there will be an opportunity to ask them. Thank you for joining us today. Now to Erica Sward, the Assistant Vice President of National Advocacy at the American Lung Association.
Thank you, Leo. Good afternoon. This is Erica Sward at the American Lung Association in our Washington National Office, and I'm very excited today to welcome you all and those listening in the future to our webinar, Tobacco Cessation and Private Insurance under the Affordable Care Act, and some of the new opportunities for public health that now exist both as a result of the ACA and some exciting new updates this year. We will go through the team who will be presenting on the call today. I'll be joined by Jennifer Singletary, Thomas Carr here in our Washington National Office, and then also joining us from Minnesota, we're very excited to have Amanda Jansen with Clearway, Minnesota. So this is just a brief outline of our agenda for those of you who are still dialing in. We'll go through the introductions and welcome portion, which we're clearly in the middle. Jennifer Singletary, who heads up our Tobacco Cessation Policy Project, will go through some background and the guidance that was recently issued that really gives the public health and other communities so many new chances to expand tobacco cessation coverage. Going to hear from Amanda about what states are doing, including in Minnesota, and then Thomas Carr will walk you through a new toolkit that the American Lung Association has produced. We are taking questions and answers via the online portion of the screen today, and so what we would encourage you to do is to submit questions through the chat feature as the discussion progresses. So if you have a question during Jennifer's portion, please submit it, and we will queue up all of the Q&A until the end of the discussion. But please, again, feel free to submit your questions as we go along through the online chat function. And with that, I'm going to turn it over to Jennifer Singletary, our Director of National Health Policy, for some more background.
Okay, great. Thank you, Erica. Welcome, everyone. It's great to talk to you today. So I'm going to do the first two sections of this webinar, give you some background on the ACA and tobacco cessation, and then talk about the new guidance, which is why we're all here. So let's go ahead and get started. Before I get into the meat of the presentation, I wanted to define my acronyms. I am in DC and we tend to use them a lot here. So we just wanted to let you all know what I'm talking about. So the ACA is the Affordable Care Act, or healthcare reform, or whatever you would like to call it. HHS is the U.S. Department of Health and Human Services. They are the main agency implementing the Affordable Care Act. There are two others, Labor and Treasury. We are less concerned with them because HHS is doing most of the coverage requirements, which is what we'll be talking about today. CMS is the Centers for Medicare and Medicaid Services. They are part of HHS, and they're the main sub-agency, essentially, who is implementing all the requirements for ACA. The worst acronym on this list is USPSTF, the United States Preventive Services Task Force. I will explain what they are in future slides, just so you know what that horrible acronym stands for. And FAQ, you're probably familiar, but just in case, FAQ means frequently asked question, and you'll see why that's relevant in a second. The last thing I just wanted to mention is I will probably use these terms interchangeably, exchanges and the state health insurance marketplaces. When you hear that, know that I mean the new marketplaces set up in each state, either by the federal government or by the state, created by the ACA to provide insurance to people who couldn't afford it or couldn't buy it before. So let's get going. Say what you want about the Affordable Care Act, but I don't think anyone could deny that it places a stronger focus on prevention in healthcare. Many examples of this, including the Prevention and Public Health Fund, which the law created. It created pilot programs to test prevention strategies through Medicaid. It added a new prevention visit in Medicare Part B. And most importantly, what we're talking about today is it added requirements for many health plans to cover preventive services with no cost sharing. Before I talk about what that means, I want to talk about which plans this requirement applies to. So in the left-hand column are the plans that, the requirements that I'm about to talk about. These are the plans that it applies to. So first of all private plans, all private health insurance plans. So that's, most of us on the phone probably get our health insurance through our employer, and that's a private health insurance plan. This also includes plans sold in the exchanges or the marketplaces in states. It also includes small group and individual plans that might not be being sold in the exchange. Someone has gone out and bought one of those plans on their own. That also applies to those plans. This requirement also applies to Medicaid expansion plans. So that is in the states that have elected to expand Medicaid, those newly eligible people for Medicaid, the plans offered to them, this requirement applies to. Plans that this requirement does not apply to, they have different requirements. That's a whole different webinar, which we're not going to talk about, just to bring out the differences here. This requirement does not apply to Medicare. It does not apply to traditional Medicaid plans, so people who are already eligible for Medicaid and in the Medicaid system before January 1st, 2014. This does not apply to the plans offered to them. And this requirement also does not apply to grandfathered plans. So those are plans that were in existence before March 2010 when the law was passed, and have not made significant changes since then to trigger losing their grandfathered status. Those grandfathered plans don't, many of the requirements of the ACA do not apply to grandfathered plans. So now let's talk about preventive services and what we mean by this requirement. So the law has 4 categories of preventive services that are required to be covered in the plans I just talked about. Routine immunizations, preventive services for children and youth, preventive services for women, and all those 3 categories are linked to specific lists of recommendations, which I'm not going to get into because we're most concerned with the 4th bucket, which is preventive services given an A or B recommendation by the USPSTF. So what is the USPSTF? It is the U.S. Preventive Services Task Force. That is an independent volunteer panel of national experts in prevention and evidence-based medicine. This panel of experts makes recommendations based on evidence for clinical preventive services. These recommendations are written for clinicians, and that will be an important point in a couple slides from now. So they're written for clinicians, for healthcare providers, essentially to tell them, okay, I have this patient in front of me, they are this gender, this age, they have this medical history. This means that I should be giving them preventive service X, Y, and Z. Guidance on what preventive services they should be getting. The panel assigns each recommendation, so each preventive service that they address, they assign a recommendation, a letter grade, and that's based on the strength of the evidence and the balance. They weigh the harms and the benefits of delivering that preventive service to the population they're talking about. And the grades they give are A, B, C, or D. They do not give Fs, but they do give Is, which stands for incomplete, meaning there is not enough evidence to determine whether this is a preventive service they should recommend or not. So what kinds of preventive services do they address in these recommendations? There are a lot of cancer screenings in the list, and I encourage you, if you're interested, go to Google U.S. Preventive Services Task Force. They have a nice list, alphabetical list. Click through, see what recommendations you're interested in. They include a lot of cancer screenings. Of course, the Lung Association is particularly interested in the new B recommendation for lung cancer screenings, but there are other types of cancer there as well. There are immunizations, blood pressure screenings, cholesterol screenings, STI, etc. And of course, today we're going to talk about the tobacco recommendation, cessation, tobacco cessation. So there are 3 recommendations that concern tobacco from the USPSTF. The first one is the one we're going to talk about today, which is the A grade for cessation counseling and intervention. There are 2 separate recommendations, but they basically say the same thing. They're just for different populations. There's an A grade recommendation for adults over age 18. And then there's also a recommendation, also an A, for pregnant women of any age. So those are the 2 cessation recommendations, both given an A, which is the highest level of recommendation. There's also a B grade recommendation for education and brief counseling for tobacco prevention. So this is not cessation. This is not helping smokers quit. This is preventing kids from starting. And that recommendation is for school-aged children and adolescents. Again, that's prevention, not cessation. We're not going to talk about this anymore, but I just wanted to mention that that is also a recommendation included in the USPSTF recommendations. So now that I've given some background, I'm going to go into the cessation guidance, which is why we're all here today. So before I talk about the guidance, I want to tell you how happy we were when it was released. So the USPSTF makes these recommendations, and as I mentioned before, they were created for clinicians. So they are aimed at doctors and other healthcare providers who are interacting with a patient. They were not written as insurance policy language. The ACA kind of put these recommendations into a new role, perhaps elevated their importance, at least among some people. And there were some problems in translation. Some of the recommendations are pretty easy to translate. It's a simple thing like mammogram, people of X age and gender should be given a mammogram. That's pretty straightforward. With tobacco cessation, there are 10 treatments that are recommended for tobacco cessation, and the USPSTF recommendation did not, it wasn't black and white. It didn't say, okay, this recommendation means that insurance plans should cover X, Y, and Z. That was the connection we were missing. Because of this kind of vagueness with the recommendation, we were seeing evidence showing that plans were interpreting the requirement very differently. It really depended on what plan you were talking about as to what cessation coverage was offered. And evidence also showed that most plans were not covering a comprehensive cessation benefit. They were not covering all the treatments recommended. And the requirement for preventive services in private health plans has been in place since 2010. So this is where our evidence is coming from. It's been 4 years. We're seeing complete variance in what is being covered in plans. And there was actually even one study related to my last bullet here that showed that coverage of tobacco cessation was more of a mess than some of the other preventive services, which goes to my point of some of them are more straightforward. Tobacco cessation is not one of those straightforward ones, and we really needed guidance from the government saying, what does it mean when you say we have to cover tobacco cessation as a preventive service? So the Lung Association and many of its partners, many of you on the phone, I'm sure, contributed to efforts to ask HHS and the other agencies to give us this guidance, tell us what you mean, give us guidance for the health plans so they know exactly what they're supposed to cover. And on May 2nd, 2014, the guidance came out. It was released, yay! It was released by, the 3 agencies implementing the ACA, so Health and Human Services, Labor, and Treasury. The guidance was issued in the form of an FAQ, That's where that acronym comes in, FAQ. And those three departments often release FAQs about the ACA. There's actually a whole website devoted to it for clarifications, and when they hear questions coming in, they will use these FAQ documents to clarify what they mean, clarify regulations, and give guidance. So this particular piece of guidance was given in ACA Implementation FAQ number 19 in Roman numerals, and it's question 5. So just to note that if you end up going to our toolkit, which Thomas will be talking about later, and you click on this FAQ, just know that you need to scroll down to Q5, because if you don't scroll down, you're going to think you're in the wrong place. So just to know, to scroll down to Q5 to get the actual language from the guidance. So what does the guidance say? It gives a great definition of a comprehensive cessation benefit. It says that plans should be covering at least 4 sessions of individual, group, and phone counseling, at least 90 days of all FDA-approved smoking cessation medications when prescribed by a doctor. And if you don't know, those 7 medications that are recommended by, or that are approved by FDA are the nicotine patch, gum, lozenge, nasal spray, and inhaler. And then non-nicotine are 2 medications, bupropion and varenicline. So those are the 7 FDA-approved cessation medications, and all of these treatments, these 10 treatments, individual, group, and phone counseling, the medications I just listed, they are all recommended by the Public Health Service as being safe and effective for helping smokers quit. In addition to this list of treatments, the guidance also said that at least 2 quit attempts per year should be covered. We encourage plans to cover more than that, but at least 2, because we know quitting is a process and sometimes people relapse or need multiple times to try. Also, the guidance reiterated what the law says, that there is also supposed to be no cost sharing for any preventive service. Cost sharing means any amount of money that a patient pays to get a treatment. It's usually in either a copay, which is, say, when I go fill a prescription, I have to pay $15 for generics and $20 for a brand name, that kind of thing. We're probably all mostly familiar with that. It can also be co-insurance, which is when you have to pay a percentage of the cost. So say your medication costs $100 and you have to pay a 20% co-insurance, so you'd be paying $20 for that medication. And lastly, this can also include deductibles. So these preventive services, you are not supposed to have to contribute towards your deductible to get these. And lastly, the guidance says that these benefits should be provided with no prior authorization requirements. Prior authorization is when a patient or a healthcare provider has to essentially ask the insurance plan if it's okay for them to give this treatment before the patient can fill a prescription or before they can attend counseling. This really can slow down someone's quit attempt. And as most of us probably know, quitting is very hard. Quitting smoking is very hard, and it really depends on your motivation. You need to be really motivated when you are making a successful quit attempt. And anything that slows down this process, it's Monday and I'm really ready to quit smoking, and then your health insurance plan doesn't say that you can take that you can use the treatment until Friday. Maybe you've given up by then. Or maybe you've decided to go it alone and try cold turkey, which we know is you're less likely to successfully quit. So prior authorization can really slow down the process and discourage smokers from trying to quit with treatment. So that's why the guidance recommends that it not have prior authorization requirements. So this is a great definition of a comprehensive benefit. It's what many public health organizations have been advocating for a long time. So we were all very excited to see this guidance come out. And of course, I know that all of us wish that when we write something down on a piece of paper and release it, it just magically, poof, everyone just follows it and we're all good and the job is done. We know that doesn't work that way. So our job is not done. We have the guidance now, but we all need to work together to build education and awareness about the guidance among various audiences. So I've listed 4 here that we consider the most important and relevant here. State regulators, so that's your health insurance commissioner and the people that are involved in running your state exchanges, your Medicaid expansion program, the folks, the policymakers at the state level who have enforcement capabilities and are really implementing, the Affordable Care Act is implemented at both the federal level and the state levels. State regulators have a big role, are playing a big role right now. It's also important to educate and build awareness around health plans. Obviously, they are the ones who are giving the, issuing the policies and determining coverage. So that's definitely an important audience. As well as healthcare providers. And I'm sure some of you on the phone in the webinar are healthcare providers, and you know that it's very difficult to help a smoker quit when you have no idea what is covered under their health insurance plan for them. So they are a really important audience to educate about this FAQ. And lastly, consumers. So, reaching out to the smokers out there who maybe didn't have great cessation coverage before, and now their plan is supposed to be covering this great benefit. So making them aware of that and making them aware of what their plan should be covering. And so if their plan says, no, that's not covered, teaching them what to do when that happens, who to call, how to get the coverage that they should get. Some states have already taken action, like what I was saying before with reaching out to those 4 different audiences. And I will just say that the states on this slide are the states that we know of. If you're looking at this slide and you say, hey, my state should be there, please contact us. And
you can even type it in.
Yes, please type it in, but I would rather have it in an email anyway. So we'll have our emails up at the end of the presentation. So please let us know if you think your state should be on this slide. We are trying to keep track of what's going on. But here's what we know. We know that in Illinois and New Mexico, the health insurance commissioners have basically proactively reached out to their health plans with a document, a bulletin, however they normally communicate with health plans, saying this is the guidance we've received. We expect you to follow it. We expect you to cover the treatments listed in the guidance. We also, at least I know the Illinois one, the Illinois bulletin also says that you need to report to us your coverage for preventive services, which is great because tracking is always good. So we know that has happened proactively in Illinois and New Mexico. We also know that in Minnesota and Washington, the health insurance regulators have taken a bit of more of a reactive position, and that they're not, they haven't released a letter or a bulletin to plans, but they have indicated officially that they will be using this guidance to enforce plans when they submit their coverage information. So that's great as well. There's also an example from Kansas where the health insurance commissioner actually sent a press release out to try to reach the public. So this is the consumer bucket of people I was talking about, educating them on what their plans should be covering and what to do when they encounter a plan that's not covering these treatments. So now I'm going to throw it to Amanda Jansen to talk about her experiences in Minnesota, which obviously Minnesota was on the slide I just talked about. Amanda?
Yeah, thanks, Jennifer. So I'm Amanda Jansen. I'm Senior Cessation Manager at Clearway, Minnesota. And before I start, I'll just do a little quick 101 on Clearway, Minnesota as an organization. We were created in 1998 with 3% of Minnesota's settlement with tobacco companies. We're a life-limited organization that will close our doors in 2023. We're an independent nonprofit that works to eliminate the harm that tobacco causes the people of Minnesota. We do this primarily through our grant-making programs, our cessation services, and our statewide outreach activities. We have an array of cessation services for all Minnesotans, and we also run the state's quit line for uninsured and underinsured Minnesotans. So as a life-limited organization, we have 3 different legacy goals that guide our work. The legacy goal that is relevant to the work I'll talk about today states that 100% of Minnesota smokers will have access to comprehensive tobacco dependence treatment by the time we transition out of existence in 2023. So we've done some work in all 4 stakeholder groups that Jennifer mentioned: state regulators, health plans, providers and health systems, and consumers. So I'll share a little bit about our work in each of those areas, along with some lessons learned. So first with state regulators. Our work with state regulators has focused on ensuring that they're implementing the ACA cessation guidelines in a comprehensive way. That is, that they're interpreting the cessation guidelines as to mean exactly what the FAQ outlines. So in Minnesota, just a little landscape, there are 3 different state agencies that we're working with. First, the Departments of Commerce and Health, who jointly regulate our insurance market. The Commissioner of Commerce is equivalent to our insurance commissioner. And then there's the Department of Human Services, who runs our state's Medicaid program. So we first began our conversations with the Departments of Health and Commerce, but way back in 2012, when Minnesota was deciding if it wanted to run its own state-based health insurance exchange. These initial conversations, including educating the agencies about what was a comprehensive benefit and how the ACA can be a tool in increasing access to that type of benefit across the state. We also stressed how ambiguous the initial ACA cessation language was and how that ambiguity impacts coverage across Minnesota. We then worked with these agencies to send a letter to Secretary Sebelius asking for clarification, and this was shortly before the FAQ was released. So now that the FAQ has been released, we've been using it as a catalyst to continue conversations with these agencies. And as Jennifer mentioned, they have described it as this is the clarification that we needed, and we're going to go forward and regulate it as such, which is great. So then our Medicaid program is close to having a comprehensive benefit. Enrollees have access to all FDA-approved medications, as well as individual and group counseling. Quitline services are not a mandated part of the benefit, and copays are still required on some medications. So since the FAQ applies to the Medicaid expansion population, we've used the FAQ to advocate for a comprehensive benefit across the entire Medicaid population. So our conversations with the Department of Human Services began at the very top with the commissioner of the department, who is generally supportive of ensuring a comprehensive benefit. We then asked the commissioner to facilitate some meetings with other staff in her agency that could work to expand the benefit. She connected us with the Medicaid director, who in turn brought other pharmacy and benefit management staff to the table, which really resulted in really productive and comprehensive discussions. We've been making good progress and are continuing these conversations this fall. The conversations have focused on administrative routes to ensuring this type of comprehensive benefit. So now with health plans, our goal here is to encourage health plans to include a comprehensive cessation benefit in all of their products. In Minnesota, we have 8 major health plans, all of which are nonprofit, and many of which operate their own quit line. So since we operate the state safety net quit line, we had some relationships already built with the health plans before beginning these benefit design type of conversations. But even given those existing relationships, assessing the coverage landscape for cessation services was still very hard. So we first started in late 2013, before the FAQ was released. We started conducting interviews with the health plans to better understand 2 things: what benefits and services were they offering and covering in their products, and 2, how are health plans interpreting the initial ACA recommendations around cessation. So now that the FAQ is out, we're meeting with leadership at health plans to both share information about the FAQ as well as share our summary findings of the interviews we conducted. So the summary findings were our initial reason to request meetings with the plans, but we're now also able to educate about the FAQ and learn what the plans are doing in other ways to address tobacco use among their members. So providers and health systems in general, we think are still really digesting how the ACA is going to impact the care they're providing. Specific to the new cessation FAQ, They may be asking themselves some key questions such as, what does this mean for our providers? What does this mean for reimbursement? What does this mean for how we're treating our patients? And what does this mean for our systems and processes? We have worked with health systems via granting initiatives for quite a while now. Our broad goal with this work is to support health systems to implement systems change for assessing and addressing tobacco use. We're currently funding 3 health systems, which started on May 1st, and a current request for proposals out to fund the next round of health systems in doing this work. The bottom line is that the ACA impacts these health systems on a much larger scale. Our tobacco-specific grants have raised questions for our grantees about how the ACA impacts tobacco dependence treatment. Health systems are just starting to think about the FAQ itself. So as our grantees continue to digest the ACA, there may be opportunities for us to play a role as educator, convener, technical assistance provider. Health systems may also choose to incorporate information about the ACA guidelines into provider trainings or other grant activities. So with consumers, Clearwater, Minnesota has traditionally engaged consumers around quit plan services via mass media campaigns and other outreach efforts. We have just begun thinking about if there are opportunities to educate consumers about cessation coverage more broadly and what our role may be in such efforts. So we'll be continuing these discussions over the next several months, and of course would welcome any examples from other states or organizations that are doing this type of outreach. So I'll finish with some lessons learned that really span across all of these stakeholder groups. First, use the FAQ as a catalyst for relationship building or reconnecting. So if you don't already have a relationship with these stakeholder groups, use the FAQ as your reason to reach out to them, as your reason to open that door. If you already have relationships with these stakeholder groups, you can really use the FAQ to refresh the relationship or continue conversations that may have stalled out previously. Second, gather and share examples from other states. All of these stakeholder groups have asked this question: what are others doing? So you should be prepared to provide materials from other states. Being able to talk about how your state is either paving the way or aligning with other states will be really beneficial. Also, if your state has not done a lot of work in this area and has more work to do, pointing out what other states are doing will help make that case. 3, you should ask for advice and ideas from stakeholders. Don't come with all the answers for how to implement the FAQ in a way that increases cessation coverage. When you're meeting with these type of stakeholders, really focus on creating a shared goal around increasing access to coverage. You can do this by educating the stakeholder on what the FAQ says and what opportunities it creates for expanding access to coverage. Then you can ask for their advice, ideas, recommendations on how to accomplish this now shared goal using the FAQ as one of the tools. So when we approach these stakeholder groups, we did it with the recognition that they likely know best when it comes to outlining tactics and more of the how. We came to the meetings with ideas, but asked for their input and recommendations and strategies as well. It was also a really good way for us to gain some buy-in for the work we were trying to accomplish. 4th, frame coverage access in relation to other tobacco control efforts. So talk about FAQ opportunities in the context of a tax campaign or health systems change or local policy efforts, other statewide legislative campaigns. Help stakeholders see how access to coverage and implementation of the FAQ complements and fits into a broader tobacco control movement. Finally, ensure that different state agencies are interpreting the FAQ consistently. There are multiple players in the insurance market, and you can't assume that these agencies work together on a regular basis and that the decision of one agency will trickle down to another agency. So for example, in Minnesota, 2 different state agencies were interpreting the FAQ in different ways. We brought this to their attention and facilitated conversations around a shared understanding and interpretation of the new guidance. With that, I will turn it back over to Thomas Carr.
Great, thank you, Amanda. Quickly before I start, just wanted to say, if you do have questions, please you can put them in the Q&A box, and you should be able to see on your screen. So, once again, I'm Thomas Carr, Director of National Policy with the American Lung Association. And I get the privilege of being able to take you through some of the tools and resources the Lung Association has created and assembled for your use in education and advocacy around the new cessation guidance. The online toolkit is live. The address is up at the top of the screen, so feel free to check out the web address if you want to as you follow along here. So first of all, this is a section on has a number of fact sheets and materials you can use in your states. The documents vary in length and detail. So for example, the Cessation FAQ Basics at the top is a one-page fact sheet that's really appropriate for most audiences, while the How to Design a Tobacco Cessation Benefit is 5 pages and much more detailed. As you can see also, we have several fact sheets and materials listed as coming soon. A few notes about those. We're composing an FAQ on the Cessation FAQ, and we'll include a number of the questions we get here today. So again, if you have questions, please enter into the chat box. Also, please send us information if your states take action concerning the cessation guidance, as Jennifer mentioned before, so we can include them on the map that we're creating. We want to make sure you give any states that are doing work on this issue credit, but we have to have an official document to link to. And then we've also got some template materials and toolkit and template materials and letters that can be used for various stakeholders on this part of the toolkit. The materials download as Word documents and are unbranded currently, so very much of use for anybody who wants to use them. One thing to note, we are working on a few updates to the template letters you see up there, and we'll have updated versions posted in the toolkit by Wednesday of next week. So make sure to check back then, and you may see some updates. We'll make sure to note that the versions there are updated. And we've also got some state examples. Jennifer talked about many of these before, but taken action already concerning these are states that have already taken action concerning the cessation guidance in various ways. We hope to add New Mexico once we get a document to link to, and any additional states that take action, we hope to add examples as well too. These are external links. And then finally here, regarding a couple more sections, webinars and video posts, and then a few other important links to lung association sections of our website, and also the Federal Employee Health Benefit Plan program materials, which has a very good benefit as well too. Regarding the webinars and video posts section, we plan to do 20-minute downloadable videos aimed at other cessation guidance audiences listed up there. So feel free to visit the toolkit over the next several months as we finish these up and post those. Also, to head off one potential question, you will be able to watch a recording of today's webinar in this section. The RSVP link will be replaced with a link to the recording. So as you see there, instead of RSVP, you see a link to the recording. And finally, as noted previously, we plan to add additional materials and resources to the toolkit as we go along. If there are additional resources missing that you think might be useful to you, you can feel free to put that in the Q&A box as well too, or contact us afterwards. So really open to ideas, and we want to make this toolkit as useful as possible for you. And so with that, let's turn it over to some questions.
So hi everyone, this is Erica Sward here again in the Washington National Office, and excited to see that we have so many questions queued up, and we will start to go through them here. But I did want to just kind of note from a couple of summary perspectives. First of all, I want to thank all of our presenters, especially Amanda from joining us from Minnesota, and highlighted just a couple of the points that Jennifer made that I think and that Amanda underscored that I think are so critical. Number one, the particular slide was really critical for understanding what a good definition of cessation guidance is, and that's something that you can share widely. Just in general, those points from the guidance, and that's something that the tobacco control community and the prevention community as a whole should work through and provide. Number two, we want to just highlight, I think, the real problem that we're having a good comprehensive cessation guidance and benefit coverage for people in Medicaid expansion and private health insurance plans, but unless you in your states work to do something proactive right now so that the same good benefit applies to traditional Medicaid, that's not going to happen. and the people who, again, really need that critical help are not going to get the help they need. So with that, let's go for the first question. The first one, just a quick clarification, do private plans include insured and self-insured individuals? Jennifer.
Yes, they do. When I say private plan, I mean any type of private insurance. That is an important distinction for some things, but in this case, this requirement applies to fully insured and self-insured. For those who maybe don't know that distinction, fully insured is, say, an employer, basically pays an insurance company to take their employees and cover them for health coverage. A self-insured employer takes on the risk themselves and administers the plan themselves. So, but despite that important distinction, it applies to both of those types of private plans.
And are most of the private commercial plans grandfathered in, or are they in the non-grandfathered category?
So the answer to that question is changing constantly, and the number of grandfathered plans is getting smaller and smaller. It depends on who you ask as to how many plans there are or what percentage of plans are grandfathered. I've heard 30% now, but don't quote me on that.
There's no real good source for that information.
There's not a great source. Yeah.
Okay. Could you walk us through, and this is a question that just came in, is the cessation FAQ requirement or is it a recommendation? How does that work?
So the ACA requires all non-grandfathered private health plans, as I just mentioned, and Medicaid expansion plans to cover tobacco cessation as a preventive service with no cost sharing. Like I said, because tobacco cessation receives that A grade from the U.S. Preventive Services Task Force. The FAQ guidance that we talked about today provides guidance and more details on this requirement, and it includes specific treatments to cover. The FAQ says that in order to be in compliance with the guidance, the insurance plan must cover all treatments listed in the guidance for the duration specified, allow at least 2 quit attempts a year, not require prior authorization, and not require cost sharing. It is unclear to us right now how compliance with the guidance will be enforced at the federal level.
But I think one of the things that would be helpful from the Lung Association's perspective is if you know a health insurance plan is not, that falls into this, it is not meeting the guidance laid out by HHS, please contact us, because we would like to hear about that so that we can follow up, and whether it's anecdotal or documented, we would find that to be very helpful. And I now have everybody's resources and contact information up on the screen. Jennifer, just to follow up on that, we got a question about whether the 4 sessions mean 4 sessions total or 4 group, 4 individual, and 4 phone counseling sessions.
I think that would depend on what the patient decides. But I would tend to interpret it as, the patient decides which format to use, and then it should be at least 4 sessions of that counseling format. That's my interpretation of that.
Great. We just got a question about copies of what Illinois and New Mexico regulators shared with their health plans. And again, that's available on our website, lung.org/cessation guidance.
The Illinois one is.
The Illinois one is.
We're not, I don't know if we have something for New Mexico yet, but we're working on that.
We have seen the document, but it is not, well, at least last time we checked, they haven't put the link up to it. But once they do, we will include that.
We'll add that.
And a helpful shout out from someone in Kentucky saying Kentucky is about to provide guidance as well. Wonderful. We will look forward to tracking that down. So thank you so much. Let's see. Have we found return on investment studies to be useful in speaking with stakeholders? And as the lobbyist in the room, this is Erica, I will say absolutely. We know that, and we really go back to our overused line that cannot be overused enough, which is helping smokers quit saves lives and money. And we have documentation of that that can be reached through this landing page, lung.org/cessation guidance, but you can also find it in our Helping Smokers Quit report, and more evidence on the return of investment there. But yes, in terms of our overall argument, yes, When you help smokers quit, you save lives and you save money, and that's an effective argument.
I wanted to ask if Amanda might have some experience when she was reaching out to her stakeholders of using ROI information.
That'd be great.
Yeah, we use it frequently. Actually, on the Clear Eye Minnesota website under the policy tab and then cessation policy, we have an ROI fact sheet that kind of talks about ROI for each of these different stakeholder groups all in that fact sheet. So people can either navigate there to see it or email me, and I'm happy to send them a copy. But we found it very beneficial.
Thank you very much, Amanda. We've gotten a number of questions asking if we will make this webinar public, and the answer is yes. As we shared, the recording will be available on the landing page. And also, please email. We will also make the slides available. If you contact Jennifer or Thomas, we will give you the slides. They won't contain notes, but they will include our slides if you want to repurpose them. And we just appreciate you acknowledging the Lung Association with that. So we got one question. Jennifer, I'm going to turn this over to you. Could you provide the citation or link for the study that found that tobacco cessation guidelines by plans varied more than for any other preventive service? And where might we find that in some of our existing materials, since we cited that well before?
Yes, so that is a study from Colorado. And I would have to go through our materials to see where it is, but if you shoot one of us an email, we're happy to provide you that citation, and we'll make sure it gets up on the toolkit in some form.
Really appreciate the suggestion that we may want to consider a video post for employers as well. So thank you, that's a really good suggestion. Is there a definition that qualifies cessation, an intervention service, as a preventive service in the qualifying definition of the FAQ or someplace else? I think that this really goes, cessation is one of those preventive services that receives an A from the U.S. Preventive Services Task Force. And as a result, it is a preventive service and therefore meets the guidelines and the qualifications outlined in the Affordable Care Act.
Yeah, the fact that it is a recommendation by USPSTE, according to the law, the ACA law, that makes it a preventive service. It's any service that has an A or B recommended by them.
Okay, great. Question or clarification, really. Are the publicly funded insurance plans already implementing the FAQ guidance? Publicly funded meaning Medicaid. I mean, let's go through the Medicaid, Medicare, and then traditional with Medicaid expanded to traditional Medicaid versus expansion.
So, like the slide I had with the list of different types of plans, the plans that that don't have this requirement are Medicare, which is of course federally publicly funded. And then traditional Medicaid, which is federal and state funded. They do not have this preventive services requirement. We do have information about what tobacco cessation coverage is for those two plans. I can tell you quickly, Medicare covers individual counseling, and that's up to 4 sessions of individual counseling. Through the Part B, so that's the physician healthcare services part, and they also cover the prescription medications, so not the over-the-counter. The prescription tobacco cessation medications are the nicotine nasal spray, inhaler, and then bupropion and varenicline. So Medicare, all the Medicare Part D plans are supposed to cover those medications. It does not cover the over-the-counter medications. It also does not cover group counseling or phone counseling. So that's Medicare. For Medicaid, each state determines its own Medicaid coverage. The one thing I'll note here is there is a new requirement under the ACA that as of January 1st of this year, all traditional Medicaid plans are supposed to be covering all 7 FDA-recommended, FDA-approved smoking cessation medications. So that's great news, and we're watching implementation of that requirement as well. If you need more information about what's being covered in your state or want to see a national picture, the Lung Association actually does track this coverage for traditional Medicaid. and you can find it pretty easily. If you go to our toolkit, you'll see a link to long.org/cessation coverage, and you can find the cessation coverage database through there, and you can see Medicaid coverage of cessation.
Wonderful. Amanda, hoping that you would be willing to take this one. We got a question. What expected pushback might we expect? Have any of, in this case, we'll say, did you in Minnesota experience any opposition worth noting? And if so, from whom?
Yeah, so I think the answer to that is still TBD. So one outline question that we have is if our Department of Commerce is going to regulate the health plans using the FAQ as guidance, what are the health plans saying to them doing that? So is there a possibility that the health plans will come back to our Department of Commerce and say, this is not a requirement, it's not written as such? So that's a question that we still have outlying for this fall. The pushback that we got before the FAQ was released from our state agencies was they didn't feel that they had the authority to further define or make the ACA cessation requirements less ambiguous. They were waiting for the federal government to issue some clarification. So the FAQ really took care of that biggest thing for us. So those are the two best examples I can give.
Great. I think, in terms of some of the other opposition, I think you just, in some ways, it's inertia and it's going uphill. This requires a proactive action in many cases by the health insurance commissioners to say what plans have to cover or should cover as a result of the FAQ. And so a lot of it is just trying to mobilize and get the attention of the Health Insurance Commissioner, and really that is, and the health plans, and then frankly the consumers to have the demand increased. And that's really where this toolkit comes in, and we hope it'll be a useful one for you. Next question, if a healthcare provider wants to write a prescription, how do they know if the prescription is covered, if someone has a covered plan or if the plan is not grandfathered?
So this is going to require, finding out if the patient's plan is grandfathered or not, it's going to take some work with the patient because if a plan is grandfathered, my understanding is that they are required to tell their members that in their member materials. So if you're a healthcare provider and you need the answer to this question, I would ask your patient, do you have your member handbook? That's usually what it's called. Do you have the information that your HR department gave you when you signed up for this, this insurance plan? It should be clearly stated that this is a grandfathered plan. Of course, it's going to be in different places and different documents. But if it's a grandfathered plan, they are supposed to make that clear in their documentation with their members. I wish that there was some national database of this plan is grandfathered, this plan is not. But as I said before, we all don't live in a perfect world where everything works the way we want it to. So that would be my suggestion for a healthcare provider.
There was a request for repeating the date for when traditional Medicaid was supposed to begin full coverage of all 7 FDA-approved medications, and the answer for that is January 1st of 2014. And again, you can find the link to our database that tracks this information through the lung.org/cessation guidance, and then look for the link to the database.
That's just Medicaid expansion, right? No,
that's Medicaid, traditional Medicaid.
Yeah.
So let me see. Let's talk, Jennifer, just a minute about coverage for pregnant women in Medicaid, because that really is that they get the gold star by their names as a result of direct language in the Affordable Care Act.
Mm-hmm. Yeah, so that is the other really important tobacco cessation-related requirement in ACA for Medicaid. And we're talking about traditional Medicaid, already existing Medicaid. So that's the other really important requirement. That was as of September 2010. So this requirement has been in effect for a while. So the ACA requires traditional Medicaid to provide a really comprehensive benefit. It includes medications and counseling and any treatments recommended by the Public Health Service. for pregnant women. So that was spelled out in the law. We wished it just said for everyone in Medicaid, but it did at least provide this for pregnant women. And we've seen over the 4 years of this requirement, states are really starting to implement this, and it's a much better situation for a pregnant woman who wants to quit smoking, and of course we all want them to.
So I just want to, we're pretty much out of time, and I apologize to those whose questions we could not get to. We will get a list of all of these, and of course you can follow up with any of the names on the screen. But again, all of us have an opportunity to work together on this, to work within traditional tobacco control coalitions, to those who work with the Medicaid population and the expansion population, to those in health insurance plan and other partners and engaged stakeholders, to reach out in different ways to the health insurance commissioners, to the plans, to consumers about the importance of adhering to the cessation guidelines or the guidance. And as you start to hear more information, please definitely email Jennifer and Tom with hey, you know, Kentucky did it, here's the link, or other examples from your state, and we'll continue, and we hope to be able to put a comprehensive map up on that page. So our time is up. Again, I especially want to give a shout out and appreciation to Amanda Jansen for all of her time today in preparing for this webinar, as well as Ann DiGiulio, who was not heard but most definitely seen and felt in terms of putting this whole thing on from our team here in Washington, and thanks to Jennifer and Thomas as well, and finally to the 260 of you who joined today. We are most appreciative, and again, we will make these slides and the overall recorded webinar available on our lung.org/cessation guidance landing page. So thank you again.
Thank you. This does conclude our American Lung Association's webinar. You may now disconnect.